Thank you so much. I was chosen to talk about primary radiation therapy for oropharynx cancer. I don't have any disclosures with the exception of the fact that I trained as an intern in surgery, so I may be a little more friendly to the surgical approach than the run-of-the-mill radiation oncologist. Both Dr. Weinstein and I have the opportunity to talk about what is largely the future of head and neck radiation oncology, which is, of course, oropharynx cancer. Did we figure out? So sorry.
But this one.
That one will work too. Awesome. Even dating back to 2012 now, there was a special section in the American Cancer Society annual cancer statistics talking about the fact that oropharynx cancer is one of the few cancers with increasing incidence, and this is largely due to the HPV epidemic. And in this pivotal paper in the JCO, you can see that while the traditional alcohol and tobacco-related head and neck cancers are going down, that related to HPV is going up with the really exponential increase in the number of oropharynx cancers that all of us will be seeing in the next 10 to 20 years. Again, our hope is that the availability of the HPV vaccine will prevent this and really eliminate this illness for future generations, but I think for all of us in practice now, this will continue to be the mainstay of what we see in the future. Now, as Dr. Weinstein pointed out, really the historic treatment of oropharynx cancer is open resection, and that's a lot of the information that we learned about the locations of these tumors, their routes of spread, the nodal involvement that we can expect, a lot that has largely populated our knowledge of oropharynx cancer as radiation oncologists has come from the surgical literature. But if we look back at really what we consider now pivotal post-operative trials in head and neck radiation, Dr. Cooper's trial, Dr. Bernier's trial, published both in 2004, a large majority of these patients actually had oropharynx cancer for both of these trials. So while now we largely see oropharynx as not a traditionally treated open surgical disease, a lot of our information about adjuvant treatment came from treating oropharynx cancer in these previous studies. Now, the other option that largely changed over the last several decades is the use of primary radiation therapy for oropharynx cancer. And the reason for this is that it works. You can find publications dating back almost 100 years now looking at primary radiation for cancers of the oropharynx, where they largely see the same things we do now, which is the longer you treat, the better the chance of cure, but also the longer this and more severe the side effects that you'll see. So because radiation therapy is effective for oropharynx cancer and for the surgical patients, those treated with open surgery, we largely had to follow with radiation or chemoradiation to get decent disease outcomes. We largely switched to a primary radiation treatment for these patients. But that was done with the techniques that we had at the time. So in the beginning, 2D radiation, looking simply at plain films and using bony landmarks to identify the areas that we needed to treat. Again, knowing those from the surgical literature and the surgical experience. And then even when we got CT and moved into 3D planning, we largely had to use conventional treatment fields like this, using opposed laterals, off-chord obliques with electron boosts to treat the primary oropharynx cancer as well as the electron boosts. Where I work, we have a large shared drive of old presentations, and I had to go back to 2001 to find a presentation where I could take these slides because we largely have stopped doing this conventional radiation technique, but a lot of our data still comes from it. And when you look at the isodose lines from plans like this, you had generous tumor coverage. So again, we had decent outcomes in terms of treating base of tongue and tonsil cancers with conventional radiotherapy. But that said, we had significant toxicities because, as you can tell from this plan, we effectively treat lateral to lateral, skin to skin with full dose. So we don't have parotid sparing, we don't have submandibular gland sparing, we don't have sparing really of any normal tissues, but we did have a generous coverage of the tumor. This was the mainstay of treatment for a lot of the trials that really have established the role of radiation therapy and have shown the evolution of radiation therapy as primary treatment for oropharynx and other cancers. There's RTOG 9003, which studied altered fractionation, so changing things from our traditional 2 gray per day fractionation to other fractionation schemes in ways to intensify treatment. So looking at hyperfractionation, altered fractionation, and concomitant boost. And you can see that about 60% of these patients were oropharynx cancer. So again, a lot of the information we have comes from similar patients as we're seeing today. Again, this was radiation alone, and unfortunately the local regional control was only about 40 to 50%, but also these were largely patients with historic oropharynx cancers, those related to smoking and drinking. The DeHanka series did a similar analysis looking at over 1,000 patients, again about 60% with oropharynx, and looking at treatment intensification with conventional therapy going from 5 fractions a week to 6 fractions a week, and in that case the local regional control was 70 versus 60%. So again, not perfect, but promising treatment with single modality radiation therapy for these patients. As Dr. Weinstein mentioned, we then started looking at the role of chemotherapy and looking and seeing whether or not we could get beneficial results by combining radiation and chemotherapy. So looking at the GORTO trial, which were 100% oropharynx, looking at radiation alone versus chemoradiation with 5-FU and carboplatin, and you can see significant increases in local regional control with the addition of chemotherapy. So largely chemoradiation became our standard of care with conventional radiation treatment fields for patients like these. So we didn't depend on our surgeons anymore for primary treatment. We moved forward with non-surgical therapies. This continued in the Bonner trial, where we looked also at cetuximab. Now, while all of these were shown to be relatively effective, they also have significant side effects. We all know patients who were treated in the 80s and 90s who come back disease-free but with significant toxicity. Xerostomia, dysphagia, poor taste, and in worst cases aspiration, neck fibrosis and decreased range of motion, and also most significant for several patients is feeding tube dependence. This patient that you see up here, this small picture, is actually a patient who I saw a few weeks ago who was treated in 1986 at Memorial with bilateral neck dissections for an unknown primary cancer, followed by definitive radiation therapy with conventional fields. So you can get a small picture of the fibrosis that you see from his neck. He clearly had treatment. And also, again, feeding tube dependence. If you look at the RTOG, altered fractionation study, the DeHanka study, the GORTEX studies, the grade 3 late complications, as Dr. Weinstein said, continue to be a problem, depending on the study, really affecting, typically between 30 and 50% of patients for those treated with conventional therapies. So this is significant. Even if we save these patients, those treated in that era have significant long-term dysfunction. Now, there were 2 parallel developments in the 2000s that have really changed astronomically what we do now. One was the emergence of HPV-associated cancers. And as Dr. Weinstein noted, these are a different breed. They're more commonly smaller primary tumors with sizable nodal disease. So right now with HGCC7, most of our patients are 4A. Now hopefully with changes that are moving forward, these will be better categorized in largely stage 1 and stage 2 in the new staging system. But right now what we need to tell patients is that they have stage 4A cancer, but their 4A is different than cancers of the lung or the breast, where stage 4 means something different. And also these are developing patients who are largely healthy with no competing comorbidities and no smoking history. So for those patients who do get cured, those long-term toxicities are even more important for them. Looking at the HPV association, again, not only does it change the cancer and change the patient, it changes the outcome. And this is just a summary of multiple trials that have been retrospectively analyzed for the impact of HPV or equivalently P16 status, showing excellent survival rates of 80 to 90% in most categories compared to HPV-negative tumors. So again, our population has changed, our cancer has changed, our expectation has changed for the future. At the same time, there have been significant improvements in what we do as radiation oncologists, even past the integration of 3D treatment planning. The development of IMRT based on this has really revolutionized our ability to treat tumor and spare normal tissues. So the ability to dose paint while immobilizing a patient, to identify targets, allocate doses based on risk, limit normal tissues, and then inverse plan so that we can provide differential total dose and dose per fraction really has revolutionized our ability to provide curative therapy for patients in the absence of surgery with reduced toxicity. You can see, and this publication is now several years old, but even after the initial approval by the FDA of IMRT for head and neck cancer, you can see the swift adoption within the head and neck world for IMRT, and that effectively is 100% at this time. And one of the reasons for this is we're one of the few radiation specialties that has randomized prospective data actually establishing its benefit. So in the PARS-PORT trial, again, which were the majority of patients had oropharynx cancer, performed in the UK, patients were randomized between IMRT and conventional radiation. And what they saw looking at grade 2 or greater xerostomia and quality of life outcomes shown on the left in red with conventional radiotherapy and in blue with IMRT, that patients treated with IMRT had statistically significant and really clinically significant improvements in quality of life and in dry mouth, which has largely been the problem that really drives our long-term toxicity, with no detriment in terms of cancer control outcomes as shown in the other panel. Now, IMRT isn't free, though. It's not treatment that patients can do and have no long-term side effects, and I think we need to be honest with patients about the expectations. I think their bodies will be different, and the list is the same as it was for conventional radiation, but I think that the intensity of these side effects as well as the frequency of them are much reduced in IMRT. So patients still do have xerostomia and dysphagia, but in terms of fibrosis, decreased range of motion, feeding tube dependence, these are all much lower than they were in the past. Looking at the PARS-PORT trial, the grade 2 or later complications are less than 30%. In recent studies looking at patient-reported outcomes, which again may or may not correlate with objective findings, 50% of patients who were treated with IMRT for oropharynx cancer had no or mild symptoms in 22 different arenas that were assessed. And there have been multiple recent studies that show that the long-term feeding tube dependence rate is well under 10%. Most studies, it's around 2 to 5%. There was in Seton et al., which came out very recently, from which I took this graph, you can see that the decrease in G-tube dependence over time from treatment is about 7% at 1 year and drops to less than 4% at 2 years. So again, looking for benefits from this when we still have single-digit long-term feeding tube rates, I think is going to be difficult when we look at new technologies. Not to say we can't make it better, but the rates of severe complications are much lower in the era of IMRT. As a result of this, looking at the need for open surgeries to have adjuvant radiation, for the success rates in terms of cancer control from primary radiation and especially chemoradiation approaches, looking also at the integration of IMRT, you can see that the trends in the use of surgery for oropharynx cancer have come down since the 1990s to 2008. And this really has largely been the mainstay of evidence-based treatment for patients with newly diagnosed oropharynx cancer is radiation, typically with IMRT, with the use of concurrent chemotherapy based on disease site and stage. But as Dr. Weinstein noticed, it's a new era. There's been the reemergence of TORS since it was approved for use in head and neck in 2009. And the rationale is, as he explained it, really we don't have surgical data for the patients that we treat now, and TORS allows us to have that. So we could, if needed, really tailor treatment based on pathologic risk factors that we would have if we treated these patients surgically up front. There's an argument that it lowers radiation dose. Now, again, the typical radiation dose right now, I think that has the best evidence, is 60 gray. I don't see a huge difference in people going out for dinner, working full-time, and playing golf in my patients at 60 gray compared to 66 gray. So I don't really foresee a significant difference. And when I talk to patients and they talk about, well, if I have surgery, you can reduce my radiation, right? And I say yes, by 6 gray or 10%, they seem a little underwhelmed by that reduction. The question is, can we reduce it further, which might be more clinically beneficial? It allows, again, for the pathologic assessment of the untreated tumor, and there's an attempt for better disease control and functional outcomes. Again, that remains to be seen as we get long-term data. And you can see that I had segmented this graph because in this recent paper you can see that this trend is changing. So from the 90s to 2008, we saw a continual decrease in the use of surgery for oropharynx patients, but now looking at the rates, and I think really just clinical practice throughout the country, you can see that with the education, with the use, with more centers getting the Da Vinci robot, you can see a significant increase in the number of TORS patients with oropharynx cancer. And the question is, we really need to figure out is what do we need to do with them, and are the traditional indications for postoperative radiation the same in the modern era, both with HPV and with TORS? Now, one major thing is that if you look at the series of TORS, and this again is a set of data that is slightly different, but all published to that shown by Dr. Weinstein, yes, there are significant publications from these groups. They continue to document what they've been doing as they increase the use of TORS in the oropharynx population with good rates of local control. But that said, the follow-up is usually pretty limited, usually less than 2 to 3 years, which again, and some of it less, 1 or around 1. And the biggest thing is looking at the number of patients who get adjuvant radiation or chemoradiation. So in most of these studies, well over 50% of patients get radiation or chemoradiation regardless. And in some of them, 60% of those patients treated with TORS end up with chemoradiation, which again gets us back to chemoradiation. So what did TORS buy us in terms of outcome or toxicity when we're treating these patients with chemoradiation, nevertheless? So this again remains a work in progress. Now, as Dr. Weinstein mentioned, there are significant ongoing trials looking at how we can de-intensify treatment for these oropharynx cancer patients that are HPV positive. And just to highlight 3 of them that I think are very important and that we should all support. One is ECOG 3311, where patients with P16 positive oropharynx cancers are enrolled and they are treated with TORS. If they have what is considered low-risk disease, T1 and 2 and 0 or 1 and negative margins, they don't get radiation. This is the arm everyone wants to be in, but not everyone is in. Because if you can get away with your treatment for oropharynx cancer with surgery alone, I think that that's the best thing for you. But that said, the majority of patients are not in that arm. For those patients that have positive margins or extracapsular extension greater than 1 millimeter or 5 or more lymph nodes, they get chemoradiation to 66 gray with weekly cisplatin, which is the same treatment we would have given them had they not had surgery. The other arm that I think is really the one that has the biggest question and may change our practice in the future is those patients with intermediate risk effects, close margins of less than 3 millimeters, less than 1 millimeter of ECE, or 2 to 4 lymph nodes. They are randomized between radiation alone with 50 or 60 gray. This is one that, again, will have significant impact for us because if we can prove that with TORS and 50 gray, we can get good long-term disease outcomes with a minimum of toxicity, I think that that would be really pivotal moving forward. As mentioned before, RTOG 1016 randomizes patients with P16 positive oropharynx cancer between radiation with cetuximab and radiation with cisplatin. This is completed and we are rating the results, again with the argument that cetuximab is less toxic. And then finally, the most recent trial that we are starting accrual for is the RTOG HN002, which Dr. Yam is the PI for, looking at low-risk oropharynx cancers and stratifying between 60 gray and 6 weeks with cisplatin versus 60 gray and 5 weeks radiation alone. Again, ways to look at altering radiation, minimizing the number of interventions to try to maximize our disease outcomes and minimize our toxicity. So overall, I'd just like to thank you for the attention. Again, oropharynx cancer is a really fascinating field to be in right now. The modern patients are different. HPV makes a world of difference, and modern advances in all fields, radiation with IMRT, medical oncology with cetuximab, and surgery with TORS really has changed things. How to integrate all of those remains to be seen. So thank you all for your time.